This is the healthcare delivery providers, part of the Healthcare Marketplace Specialization. This is Module 2.4.1, Challenges Facing Hospitals. The learning outcomes in this lecture are that we will review some of the challenges facing the various hospitals, and then we will learn about what can some of the things be that the hospitals and health systems can do or are doing around them. Medical Executive Committee. So we are headed towards the end of this module on hospitals, and this particular series of lectures in these lessons that are coming up will look at some of the challenges and innovations. So let's start a little bit looking at the challenges facing hospitals. And as you've seen through the previous modules and lectures, the hospitals are changing. Many years ago, or late 1800s, they were the place where people would go to die. And then early in the 1900s, mid 1900s, they were a place where people went to get better and better. And now in the last 5 years, more so, even in the last 3 years, there is a realization that hospitals are places where you can actually become sick. So there are superbugs, infections that are in the hospitals. There could be patient falls and other injuries. And also, if you do not need to be in a hospital, you really should not be there because that increases societal cost. So there's quite a few different challenges facing hospitals as the model transforms. Being here and being in leadership right now in the healthcare industry in the U.S., I can tell you that the pace of change and the pace of transformation in the hospital and the entire health system is incredible. So let's look at a couple of the challenges now. So I wanted to start with our roadmap again, and here's the hospital. And one of the things we will talk about is the squeeze, and I wanted you to visually see it before we dig into that a little bit more. So here's the skilled nursing facility that used to provide care for some of the patients here. And as it expands its competencies, and same thing with surgery centers, as it expands what surgeries it can do, the hospital is slowly getting pinched between these two parts of the care continuum. So I just wanted you to visually see that, and it really is bringing to the forefront the question, what should a hospital be? What services can a hospital provide that only it can provide? Let's start looking at some of the challenges. The first one we've discussed a little bit before, which is hospitalization, especially in the last few years, is beginning to be looked at as a failure of care. And that's a pretty big statement, that a patient that goes into the hospital, the system appears to have failed, and the patient should have been maintained out in the community, but had to go into the hospital. So the Medicare program began with the 30-day unnecessary readmissions, for example, for heart attack or heart failure or pneumonia, and started penalizing hospitals to send that signal. And now, actually, even admissions are being looked at. So what are some of the admissions that could be prevented by either primary care or other community-based services so that the patient does not have to go into the hospital? The next challenge that we have talked about before is the payment model transformation. So again, in the 70s and 80s, the hospital used to bring in a lot of revenue, and the higher the volume, the higher the money, and it was really keeping the health system going. And now, as the model changes towards more of pay for value, the hospitalization needs to be decreased. But if the number of patients that are hospitalized is decreased, and if the system is still getting paid according to the fee-for-service model, then how will the system actually make it, or how will it survive? So that's what I call managing the middle game. So as the payment moves from fee-for-service to fee-for-value, how exactly will the system survive as the payment slowly goes down in this model and goes up in this model. I wanted to bring up one example of Ebola. There are many other examples. Some of them are emerging right now in viral or other illnesses. So, for example, for this worldwide crisis of Ebola, that really brought to the forefront again, we need hospitals where some of these patients could be admitted and treated in isolation or with highly specialized equipment and personnel. So the safety net role of a hospital, where the hospital needs to be available 24/7, needs to have physicians and nurses on in the hospital 24/7, needs to have x-rays, needs to have lab, needs to have all of this infrastructure, and all of that structure, use it or not. So it may not be used in the middle of the night, or it may be, but use it or not, this is infrastructure is around for 24/7, and that comes at an incredible cost. So what do you do if you don't have that, or if you say you don't need a hospital 24/7? Where would those patients go? So again, that's the point of what is the safety net role of a hospital? How do you price and cost that out? And that's something that is being really looked at carefully in the US. We've talked a little bit about the squeeze. So, this is the hospital in the middle, and it is getting squeezed upstream by freestanding emergency departments, by ambulatory surgery centers, by skilled nursing facilities that might take patients even without the hospital stay. And then in the post acute setting, the skilled nursing facilities, home health care, and other facilities are taking some of the patients that would have gone to the hospital. So slowly but surely, the hospitals are starting to feel the squeeze from both sides. And again, the question is, what is the core competency of a hospital? What are services a hospital can provide that no other delivery provider can provide? And so that's something that is being looked at. And again, we are back to the triple aim. You want to make sure every single aim of the triple aim is covered, and not just cost. So you could decrease cost by moving patients up or down, but if the quality of care is not there, you didn't quite achieve the triple aim. Let's do a short quiz. Okay, so next section in the challenges is the extreme regulatory burdens. Again, hospitals are extremely closely watched and regulated by the federal government, the state government, also by various auditory agencies that show up and rigorously examine a hospital. We've already talked about the very complicated quality and other data reporting burden that the hospitals have, and many, many surveys that happen for the hospitals. So again, all of these needs infrastructure, and that infrastructure costs money. So again, the more burden and regulatory oversight there is, the more cost there will be. So there's definitely a balance that needs to be achieved between those two. We've touched a little bit on information technology, although I will not take a deep dive into that here in my course, but the electronic health records are still emerging and improving, and the technological platforms are still getting better and better every year. They're not quite where they need to be for our staff and our patients, and again, all of this infrastructure of the electronic health record costs money, and there needs to continue to be an analysis of the return on investment of these highly costly and complicated systems. The other concept that is being looked at in technology is what's called interoperability. And so if a patient, the same patient, goes from one hospital to another hospital or one hospital to a skilled nursing facility, is the electronic health record viewable and shareable across all settings of care. And right now we have quite a bit of challenge in sharing the information on the patient. Some of it has to do with privacy laws and patient request for privacy, which has to be honored. But another thing is, do the systems themselves talk to each other? And that's quite a challenge. Personnel shortages are definitely something that is being looked at. So physician shortages, nursing shortages, some of the other critical clinicians and their shortages in the upcoming years are being looked at. The other issue is the generational differences between the previous generations and the demands and needs of current and future generations. So again, human resources in hospitals and health systems are doing a lot of work looking at what will the future look like and what is the workforce needed to actualize that vision of the future. Hospital-physician relationships have been a very critical relationship for many decades. Many decades ago, the physicians would just come into the hospital and consider it to be a factory to do their procedures or admit their patients. Now, a very different relationship is evolving between the physicians and the hospitals, where now they're looking at themselves as one team with aligned mission, vision, goals, and they're both pushing in the same direction to try to achieve the triple aim for the communities and populations they serve. So again, alignment of mission and vision, and then this very important alignment around culture. So are the physicians and the administrative staff on the same page? Do they get along? Do they see the world similarly? Those are critical things that are needed before the healthcare system will succeed. The other piece that needs to be looked at, and we'll talk more in the physician lessons, is the role of the Medical Executive Committee. As we've seen and discussed, this is the committee made up of physicians that reports into the board of directors and has direct responsibility and accountability for the quality of care and oversight of physicians that practice in the hospital. So in summary, I've only covered a few of the main challenges. There are other challenges that face hospitals, but here we talked a little bit about the squeeze. So the upstream services of ASCs and freestanding EDs, the post-acute care services, and the newer healthcare delivery models are leading to significant changes for economic reasons and other reasons in the hospitals and rest of the systems. The models right now are still in flux. So we have not landed on the correct model yet, but it's being looked at, it's being transformed and innovated. So this is a very exciting time to be in healthcare in the US.